So thank you very much for inviting me to hold this little speech. This is my disclosures. I've been on the expert board of Norwegian prostate cancer patient organization since 2007 and working close with, amongst others, Daniel Ask here. So before we know where is Norway in 2023, we have to go back and look historically to understand the situation of today. So I wanted to go back to the year 2001, and there was a paper in Lancet Oncology written by Professor Fosso at that time and the Norwegian Urologic Cancer Group. And in the introduction, it stated that the European randomized study on screening prostate cancer was not anything that one wanted to go for here in Norway because of three main reasons, and we will hear of them all the time till the days 1 year ago. So the plan was abandoned for three main reasons: Norwegian doubts about the statistical power of the trial, the possible ethical implications of screening a large number of men with no symptoms, and belief that the trial would not produce clinically important results. And thanks God, we did this European randomized screening trial. Here we have got this man, Daniel Ask, and he was a bit younger in 2004. At that time, he wrote a letter in 2004, that's amazing, to the Equality and Anti-Discrimination Ombud, asking why can't we have prostate screening as we have breast cancer screening. And he has worked for that for 20 years. And he got a letter as a response in 2005 that was forwarded from this ombud to the Social and Health Directorate. And it's the same reasons as we heard from 2001, that the professional environment wouldn't support the screening and there would not be any reduced mortality. And for our friends from Holland and Switzerland, this is just to put a perspective on the mortality in prostate cancer worldwide, where we are at the top in Norway, except for Trinidad and Tobago, and we have lower mortality in Holland and in Switzerland. And the situation in Norway is that we have 5.4 million inhabitants, and out of these, as we heard, about 62,000 men have the diagnosis today. In 2021, the prevalence was 59,000, and mortality in prostate cancer is 950, compared to 1,160 males dying from lung cancer, 770 in colorectal cancer, and 590 women in breast cancer. So it's quite high, but the good news is that it is becoming lower. And as Daniel Ask alluded, the numbers of young men is 8 times higher in 2013 compared to 1993. So 660 patients were diagnosed in 2013, and that number is even higher these days. And as we see, the blue line is going down, though that means that the patients 80 and older have a lower incidence today, so we don't screen that many, and that's good news. The good news is as well that the mortality in Norway and Sweden is dropping. If you look at age-standardized mortality drop, so in Norway the numbers are 28% less, and in Sweden 20%. And that is believed to be because of the opportunistic screening that is going on in society today. In Sweden, about 6.2% of all deaths in men after age 50 are attributed to prostate cancer. And of course, if you lower mortality in prostate cancer per se, you wouldn't see any big mortality drop in the population because it's not more than 6.2% that die. And then we come back to Daniel Ask and quality of life. These are numbers from the Norwegian Recipe Registry, showing that we have about 15,000 men having hormonal treatment every year. And that is 15 times more than people that die. So it's quite dramatic. And this is, of course, a matter of quality of life for very many men. And we know from screening studies that we will have to, or we suppose that we will have 30% less metastatic disease from these screening trials that have been done, but maybe more, maybe a bit less. So just about the situation in Norway today. So as we know, just about investigation of prostate cancer, it's the finger test, it's the PSA, and there are some people arguing that we should go down to 3.0 nanogram per milliliter PSA as a cutoff. And we do today, as I think one of the few populations in all the world, a population-based MR prostate in all patients that are doing prostate investigations. And as well, we are, I think, very proud that we are probably the only country that now has taken transperineal MR ultrasound fusion prostate biopsies into the investigation. And we do it in the polyclinics, in local anesthesia, and in some of the departments even without antibiotics, because we have done some studies showing that we don't need that. So, as the situation is today, we have a Norwegian cancer registry that we are very, very proud of, and a quality registry there as well. That is very good if we would like to implement screening. And we know from these studies that 6.9% only of the patients treated have low-risk prostate cancer. So I think we do very well. Back to 2006, I was called by a man who was 46 years old in the hospital where I worked at that time with a PSA of 68, no symptoms, no family history, and he had a tumor on the right lobe and clinical at T2B. You could feel it on the right lobe. And the biopsies that were taken then were 3 + 4, 7, the Gleason score, 3 + 4, 7, in 4 out of 8 biopsies. And he was scared to death what to do, and I was scratching my head. I thought this is very odd to have such a high PSA being so young. So I took a phone to the radiologist at our hospital at that time. Already MR of the rectum was gold standard for investigation of rectal cancer. And I asked him to do an MR, and we did it, and we saw it was not that bad. It was just a localized disease. So we operated him, and he was happy. And after that, we started studies and had the first, I think, in the world, maybe consecutive 209 patients where we did MR of the prostate before operation, and we were able to show that the numbers of positive resection margins in T3 cancers dropped with 25%. So that was, I think, the start of the MR story. And then we also started to use MR in the investigation of patients with high PSA who had had prostate biopsies before. At that time, all prostate biopsies were taken transrectally. Here is the prostate. over there. I don't think you maybe see it. Here's the rectum, and it showed out that the cancer was far away from the rectum, so he had had 60 biopsies before we had that MR, and I think this was then also the first study that showed the transperineal approach with a prostate biopsy in conjunction with MR, and that was published already in 2011. And today we do then, as said, transperineal MR prostate ultrasound fusion biopsies on all patients in Norway. And coming back then to screening versus organized prostate cancer test programs. In screening, we invite men to take a blood test which will be followed up. And in Sweden, they have their Swedish way, where they have started an organized prostate cancer test program where men are informed about the possibility of taking a PSA test which might lead to investigation and treatment of prostate cancer. So it's very voluntarily in Sweden. And as said, and pointed out by Daniel Ask, the EAU guidelines have a strong recommendation of early PSA testing to well-informed men at elevated risk of having prostate cancer from the age of 50, and those who have familial prostate cancer, a history, 45 years, as well men of African descent, and men carrying BRCA2 mutations from the age of 40. Then we will probably hear about EU and prostate cancer. In December 2022, the EU Commission stated that prostate cancer, considering the current state of knowledge and the amount of opportunistic screening, countries should evaluate the feasibility of and effectiveness of implementation of organized programs. And I think that in Norway, where we have a really high-risk population, that would probably be a big success. So, a very important milestone was also the report by the Norwegian Urologic Association coming out in 2022 on the theme of prostate cancer testing, and the conclusion was that the professional environment recommends to form a national interdisciplinary expert group to establish more knowledge on cost-benefit of an organized prostate cancer test program in Norway, amongst others, through regional pilot projects. And this was sent to the Norwegian Health Directorate. And here we have the year 2004, and there 2023, and in the middle is our General Secretary of the Prostate Cancer Patient Organization, and he is looking down on the Health Directorate, who now has changed and is positive. The Ministry of Health and Care Services, they are also positive, because we had some discussions in the Arendal Political Week, and the State Secretary, he was quite convinced, I think, that that was good, but he said that he waited for signals and some advice from the Health Directorate. And then we talked to the Health Directorate, and the Health Directorate said, we are positive, but we have given signals to the Ministry of Health, but we don't talk to the politicians, we just talk to the administrators in the Ministry of Health. And the State Secretary said he doesn't have any information from the Health Directorate, you know, so it's a ball that is going down and from one to the other. And one crucial thing is that the Norwegian Urological Association is very positive now, and also the Norwegian Cancer Society has switched last year, and that is fantastic. And then we have also very good help from the Cancer Registry that now I think also is positive. So in 2023 very much has happened, but I think that we still have some people here with some big questions about where are we going and where is the situation and what is happening here. Because the health director says that would be very good, but we don't have any resources to put together an expert group, and we would support a regional screening, but we don't have any money. And so, you know, it's going a bit around, and I think, Daniel, you have to become more than 100 years, and maybe we will be coming to a conclusion. So, but thank you very much for your patience to listen to me.